Hi, my name is Chris. Thank you for tuning in. Today I'm going to be talking about IBD and pregnancy. I'm going to go over some quick facts right now, and then we're going to get to the rest of the video afterwards. So the quick facts I want you to know is that if you don't want to get pregnant, the best form of protection is going to be either IUDs or the Nexplanon. If you are trying to get pregnant, there is no inferior fertility if you have IBD. And then if you have pregnancy, there are some increased risks. So you can have miscarriage, abruption, preeclampsia, poor maternal weight gain, small for gestational age, as well as increased risk for flares. If you don't have any disease prior to pregnancy, your flare risk is going to be 30%. If you do have active disease, it's going to be 70%. The meds that you can take, pretty much all biologics are okay. You just be off of your methotrexate or thalidomides. And then when you're delivering your baby, C-section's only indicated if and only if you have active perianal disease or you have prior like anastomosis or other pelvic surgeries. And lastly, when the baby is born, they should not be getting any live vaccines, so i.e. rotavirus, within the first 6 months of life. Welcome to the video. Today I'm going to be talking about all of that stuff a little bit more specifically. Video off, my sources that I'm using for this entire video are from Dr. Mahadevan. She's from UCSF, she's a gastroenterologist, wrote a lot of papers on IBD, especially in pregnancy, and then also another paper by and G and Mahadevan as well, and that was out of Mayo. And then I also use like classic UpToDate. But in general, those are my primary resources. They're going to be in the description below. And starting off, I'm just going to talk about generally for a population-based analysis, roughly 800,000 females are going to be affected by IBD during their reproductive years. So that's the primary target that I'm trying to target with this video. And if you are not trying to get pregnant, the rest of this video doesn't really matter, but not trying to get pregnant, the primary preventative care that you can do for birth control would be LARCs, long-acting reversible contraception. Those are going to be your Nexplanons or your IUDs, and those are superior to oral contraceptives for two reasons. There is no estrogen, so there's decreased risk for VTE, venous thromboembolisms, and then secondarily, there is also decreased risk for reduced bioavailability if you have active disease when you're taking your oral contraceptives. But anyway, so if you're desiring pregnancy, the rest of the video really is for you. And so starting off with desired pregnancy, really we're going to start off with our preconception counseling. So ideally, patients should have their remission within like 3 to 6 months prior to wanting to conceive. And that's without the use of steroids. And that reduces the risk for flares later on in the pregnancy. Because if you have quiescence or no disease, you're roughly around 30%, but if you have active disease at the time of conception, it goes up to as high as 70%. From a genetic standpoint, you can go to a counselor, but generally, if you have IBD from a single F1, so one parent, so you, the mom, have it. If you have Crohn's, then it's 2.7% chance that the baby's gonna get it, and ulcerative colitis is around 1.6. In total, any IBD transmission from parent to baby is going to be around 1.6 to 5% if one parent has it. But if two parents have it, then it can go as high as like 30 to 33%. So that's the genetic component of it. And then going down to fertility. So if you don't have active disease, you're non-inferior fertility compared to general population. So don't think that, oh, just because you have IBD, even if you don't have disease, that you're less likely to be fertile. This is a caveat, though, that if you've had prior pelvic surgery, so like fistula repairs and stuff like that, because of your disease, you can go as high as like 3 times decreased likelihood to become fertile. And really, if you haven't been able to get pregnant within 6 months of trying to conceive, it would probably be important to start talking to your REI doctor and seeing what other management options there can be for you. In addition to that, really, it is not bad if you would think about doing egg retrieval as well as you're over the age of 30, because there's decreased ovarian reserve risk that might be present there. And in general, any biologics that you're currently taking right now do not disrupt fertility, and the biologics do not disrupt the ability to do an egg retrieval. And then, so that's primarily so that we went over, the genetic component of it, then we went over kind of the fertility component, and now the next thing that I want to talk about in regards to preconception counseling would be the medications. And the two main medications that you should not be taking would be methotrexate and thalidomide. Those should be stopped at least 3 months prior to conceiving. Those are category X for those medications. Pretty much all the other medications are okay. Ideally, we would not want patient to be currently on steroids. The only indication for steroids would be with active disease for management in regards to that. Any sulfasalazines the patient's on, their folate recommendation would be going up to 2 grams. And if you're on AZA as well, variable data on this, but really it's generally going to be okay. If it's monotherapy, it's more than okay, but they usually won't want to start a patient on it in general. So jumping past preconception counseling. So now you're watching the video and you're pregnant and you have IBD. So A, congrats. B, now let's go over the next 9 months and kind of see what that trend or what we're going to be looking like in regards to how it's going to be managed. So the first portion right now is going to be monitoring. So this is #teams. So you're going to have a lot of friends in your corner. Those are going to be your GI docs that you're normally seeing in general. You're going to have MFM, which is your high-risk doctors, as well as your general OBGYN, who's going to be managing your course throughout pregnancy. So for the GI docs, if you have no disease, first trimester, second trimester, you're going to be seeing them. They're going to be asking for like a CBC, CMP, albumin, and they're going to be tracking those and making sure that those are okay in their normal levels. Your MFM doc is going to be specifically important during the 3rd trimester because they're small for gestational age, and poor maternal weight gain associated with IBD is going to be important to make sure that the baby does not have is not really growing too small. So they're going to be doing fetal growth assessment within the 3rd trimester as long as you have no disease. And really the other things for that is really OB is going to be doing everything else. So they're going to be monitoring you through all the trimesters. They're going to be assessing for everything. It also can be possible that they can be doing a Fecal Calprotection, and this can guide intestinal inflammation. And there was a paper that came out that I'll put in the description that stated that really if you're taking it, it doesn't change during pregnancy, so it's a good marker for intestinal inflammation to assess if you're having active disease. The last thing for monitoring as well as you get further on in pregnancy, you have something called group beta strep assessment, and this is a swab. And this is important, and it'll be done usually at 35 weeks of gestation, and this is going to check to see if patients have GBS. 30% of patients have it in general. It's like if someone has freckles or not or whatever. But it's also during that time it's important to monitor for perianal disease because that's a huge situation for patients with IBD. So they're going to be doing a GBS 35 weeks as normal OBs would, and then they're also going to be checking for perianal disease during that time frame. So after monitoring, there's also medications. And so for the medications right now, stool softeners are definitely recommended to kind of help with the flow, so as long as you're not having any constipation really. And then you should be having your B9, your folate, and that should be usually up to 2 grams daily. And then you would also be having your monitoring your biologics. So usually monotherapy is superior. Most medications are okay. Except for methotrexate and thalidomide, and then steroids, obviously not ideal, but for active disease is okay. And there's a small increased risk if you're taking steroids in the 1st trimester to have oral facial cleft malformation. 1st trimester only, so 2nd and 3rd trimester not really the same. And the last thing that was the big, thing that we have to worry about is flares, right? So if you're getting a flare during pregnancy and you have IBD, once again, 30% risk if you are quiescent, so having no disease, 70% risk if you have active disease at the start of conception as well. And that's a super huge thing because if you have active disease or perianal involvement, there's a 4 times risk of you having a 4th degree laceration, which is the highest order laceration that you can have during a vaginal delivery. So that would be recommendation for a cesarean section. And then also if you have active flare, GI no longer will only do it 1st and 2nd trimester, but pretty much after every single flare, up to provider, but usually it should be Q2 week. Every 2 weeks after the flare, they're going to be assessing and making sure. And then MFM is also going to come on board at that point after that flare and do usually growth scans every 4 weeks after that. So you're going to get a little bit more involvement if you're having active disease during pregnancy. And then jumping down to more of the medication specifically, and I can show the table like right here, and it can go over like some of the biologics that are available. It is a huge category of medication, but the most common one that I see provided is vedolizumab. That's called Entyvio. This is a injection, and it's given every 4 weeks. I think it's like the superior medication that's given for IBD outside of pregnancy, and that's why I see a lot of it in pregnancy. It's stopped 4 weeks prior from estimated due date. So if you're due a certain day, then 4 weeks before that will be your last injection. I also see patients on infliximab, kind of, is Remicade. That's been okay as well, but there's a ton of other ones available. And if you're on those medications, there is something called the PIANO study. This is the Pregnancy and IBD and Neonatal Outcomes PIANO study. And this helps look at patients who are on biologics and assess to see how their outcomes were during pregnancy as well as neonatal outcomes. So it's beneficial, and it's an ever-growing database right now, and there hasn't been any adverse effects from like the Entyvio or from the Remicade. And then the last thing, so you got your medications and you see the list later or whatever. The last thing is also delivery. So delivery, conversation should already be had for you about how delivery should work, but delivery should be vaginal delivery. There is no indication for cesarean section if and only if cesarean is actually indicated is if you have active perianal disease, or 2, you had prior pelvic surgery, so that is either anastomoses or fistula repairs. In that setting, it might be indication for you to do cesarean section. And then outside of IBD, if there's any obstetric indications, then that would obviously be for cesarean, but those would be irrelevant in any patient that would have it, like failed induction or stuff like that. So that'd be the other option as well. And for post-delivery, so after you deliver, congratulations, you have a baby boy or baby girl. But after that you deliver, you can restart your medications. So you know your Entyvio was off for 4 weeks, yeah? Because like, I mean, these are like immunosuppressive drugs, right? So after the 4 week, or after delivery, 24 hours after vaginal, you can restart your medications. And then 48 hours after cesarean section, you can start your medications as well. And then the last final thing that really goes out of my realm as an OBGYN resident would be, pediatric. And so for babies who been exposed to biologics, and the research I think is specifically anti-TNF, tumor necrosis factor. So if they've been exposed to those specific medications, then they should be prevented from receiving live vaccines. And I think pretty much for any biologic, they're gonna stop it as well. There was a case where a baby got a BCG vaccine, which is like for like polio, or for TB, for TB, and then ended up getting like a disseminated infection throughout the entire body. And that's because, if you're immunosuppressed, it passes through the placenta, and then baby gets immunosuppressed, and then so you get this live vaccine, which is like a real virus, and the baby doesn't really not able to fight it because babies are super weak when they're born. But that's pretty much it. I know it was kind of a little bit verbose, but I hope that helped out. If you have any questions, please leave them in the comment section below, and I'm gonna have all the links to all the papers within the description, so you will be able to peruse them at your own leisure. Thanks for tuning in. See you next time.